All right, so we are at noon, so I'll go ahead and kick us off here. So my name is Cameron Hilton. I serve as the program director for the Upper Midwest Telehealth Resource Center. Thank you for joining us today for our webinar. Today we have Micah Cassahoon, who's going to talk to us a little bit about SUD and OUD medical billing. Micah serves on the Indiana Rural Opioid Consortium with the Indiana Rural Health Association, as well as the Crossroads Partnership for Telehealth that works to implement telebehavioral health and telestroke services with 9 rural providers across the state. So just a couple housekeeping items. So if you have any questions, feel free to go ahead and drop them in the chat. Any questions Micah will wait to address until the end of the time. We will have a little bit of a Q&A session at the end. I also will be dropping in a link to a survey just to give us an evaluation of the presentation. That just helps us to know if this topic is helpful, if you would like to see additional content related to this topic, or if you would like to see something new for the UMTRC webinars in the future. So with that, I'll go ahead and hand it off to Micah.
Thank you so much, Cam. Good afternoon, everyone. I'm happy to talk to you about substance use disorders and opioid use disorders, also within the realm of medical billing and reimbursement. And so I've been currently working with the Crossroads Telehealth Program alongside Cam, as well as working in the NROC program, which is just focusing specifically on opioids within Indiana's counties and understanding like the data behind all of that. And so again, my position is a data coordinator, and I've just been focusing on understanding the gravity of the situation and ultimately trying to get a sense of where we're going in the billing area and what common similarities we can just find across, say, CPT codes, ICD10s, and different things like that. So I'm going to cover a broad spectrum of terminology and everything like that. So I'll do my best to pace myself appropriately, and we'll move forward. So as we begin this, there are my slides. So right now here, I have no conflicts of interest, so I just thought I'd state that to begin. And so for today's agenda, I kind of already mentioned, I'll be going over some ICD10 codes. I'm sure many of you are familiar with that. CPTs, common CPT SUD codes that are within the system, and then HCPCS, also known as just the Healthcare Common Procedure Coding System, and then a little bit through Medicare reimbursement, which also falls in line with some of the Medicaid reimbursement as well. So when we talk about ICD-10, we're really focusing on the International Classification of Diseases, mainly the 10th edition, which are very, very different from the 9th edition. So they function just as a really nice tabular list that allows you just to assign codes for every single type of disease, ailment, issue, or anything that goes wrong within the human body. So appropriately, it's been divided into 4 key sections that focus on, again, diseases, injuries. There's a table just for neoplasms alone, and then they have a table of drugs and chemicals, which also includes both poisons, noxious plants, and other toxic agents, and then external cause of injuries. So this is when I say ailments and diseases, this also includes different types of trauma, like blunt force trauma to certain body parts, abrasions, cuts, and different things of that nature. So for example, if we look at ICD-10, this is kind of what you would, if you were to open up a code book, this is what you would find. So you'd find the letter. So in this instance, you see there's J44.0, J44.1, J44.9. So the J just indicates where within the list that we're focusing on, because it's all in alphabetical order, starting with the letter. And then after that, the numbers dictate what type of issue we're dealing with in the body. So here, J44 focuses specifically on other chronic obstructive pulmonary disease. And then every number or just digit that follows the decimal denotes a very specific piece of that type of issue or ailment. So here, when it says 0.0, you have acute lower respiratory infection. When it has 0.1, then this has acute exacerbation. So it gets very, very different as it moves forward and you include more numbers after the decimal. I will have to say J44 is different than J44.0. So every little detail matters, especially when you're coding and you're evaluating your EMR systems and what has been logged in. The tiniest mistakes can cause deviations that do not line up with a physician's note. And so that could also affect the billing going down the line. So I know that was a lot just for this slide, but this I covered a lot what's already here. So again, what you see in the same way that I talked about how there's J, here we have F. And so F usually denotes a lot of different types of mental and behavioral disorders. And here, when it starts with F1, anything that's between, say, F10 to F19 tends to be an ICD-10 code for any type of substance use disorder. So the 1, again, refers to the mental behavioral, and the X's are just right here, are just placeholders to show what kind of number could fit in that spot, any number from 0 to 9. So here at the bottom, you can see 14.280 equals cocaine use of a moderate severe nature, which is coupled with anxiety disorder. So that's how it would be coded when you look into your code book, and you can see the specificity increases as the more numbers are added after the decimal. So here we have now a list of very common SUD diagnosis codes. So you can see F10 through F19, you're going to have alcohol, opioids, cannabis, sedatives, cocaine, stimulants, hallucinogens, nicotine, inhalants, and other psychoactive substances. And so they're all within each one. Again, you'll have very specific links to either it could be a link to anxiety, it could be a link with that measures the severity of the addiction or certain thing like that. And I also added a note at the bottom that you will expect recurring encounters within your EMR systems for behavioral health and telehealth, because when you're dealing with addiction, you have to maintain that continuous care with your patients. And in doing so, again, when we're talking about addiction, there will be multiple visits and encounters that you'll find. So usually when evaluating that, especially within our own databases, that when we evaluate, when a certain site is dealing with, X amount of cases for X type of addiction, we can kind of evaluate certain data trends based on the number of encounters that we receive within a certain block. So now there's also the list of SUD comorbidities that we commonly find alongside the different types of addiction and different substances that we find. So commonly, F41 deals with anxiety disorders, and that's, again, commonly paired with a different type of, going back, different types of SUDs. So F41 could, for example, if someone is struggling with anxiety, the use of cannabis. So you would put F12 dot whatever with F41.0, for example. So F41 is general anxiety disorder. It also includes panic disorder and PTSD. And then there are other mental disorders associated with the list that you can see there. So again, you can attention deficit hyperactivity disorder, ADHD, bipolar disorder, depression, borderline personality disorder. All of these kind of come under that umbrella of the different types of anxiety disorders, and they have links to these other mental disorders that I have there below. And so now when we look at OUDs have, we kind of separate them a little bit from SUDs. So OUDs count as an SUD, but we look at them just based on the past trends that we've seen over the years. And so we've, in my work with the Indiana Rural Opioid Consortium with NROC, we focus specifically on the F11 codes. The majority of the time spent, I'm looking at F11s, F11 specifically 0.1 and F11.2. And that's just abuse and dependence. And then just the basic use is F11.9. So here also, sometimes we won't always use F11. It could be poisoning, which is the T40 category. Adverse effects, which is, again, very similar, but there will be different numbers associated in the X's. low, and then long-term use of opiates, which is Z79.891. So again, it can get very broad, but again, the broadness of which I'm presenting to you is just to show that we don't really want to miss anything, and it can get really specific based on each type of patient and what they're going through. So again, it's kind of tailored in a way so we can understand the specifics of each individual's care plan. Additionally, it also helps to recognize that we can't just treat everything the same because people are going through different, different circumstances. So this helps increase specificity and ultimately to treat the patient with greater efficiency in care. So moving forward, we have the CPT codes. Hopefully, I again would believe that a lot of you are familiar with these current procedural terminology. And so they describe services that, again, medical professionals will provide to patients. And so usually it's a shorthand notation. I'm just universally understood by providers, payers, administrators, and regulators. So again, it's a really nice universal language understood by all. It's also linked with the HCPCS system, and I'm going to discuss that a little later because it has its own variation. And then ultimately CPTs, they have 3 categories, and we'll go over those as well. So category 1 codes, these are the codes, again, that are accepted by our health system. They're usually denoted by five numbers, and they're used by a variety of clinical locations. And then there's category 2. They're used to measure the performance, to kind of just get a quality, like a quality control of the services of what's going on. And then this instead would be, say, 4 numbers with the letter F at the end. And then category 3 would be 4 digits with the letter T at the end. And category 3 focuses on procedures and new technologies that are emerging. So there are 6 general subsections in the CPT codes. We have E&M codes, evaluation and management, anesthesia, surgery, radiology, pathology, and laboratory, and finally medicine. And then I threw a note in there just to kind of give this out. Each of these subsections can be divided into more specific areas. So again, it goes deeper and deeper as we look into the digestive system, nervous system, and all the other systems associated with the body, including cardiovascular and everything like that. So here's a really good example that you would find in a CPT code book specifically. So we have 20100, or just 20100, which would be the exploration of a penetrating neck wound. And then this is what I found to be really interesting. As we use CPT codes, they include a semicolon, and the semicolon here denotes, like, okay, this is the base code, and this is what it will always mean. And then after the semicolon, it kind of denotes, you can denote specificity. So if I were to bill for 20100, then this would be for a patient who has a penetrating wound, or you're exploring a penetrating wound of the neck. If you change it to 20101, you would say it's the exploration of a penetrating wound of the chest, and so on. So again, as the final number, as the 5th digit in the number set changes, again, you're able to denote specificity, and you can shift and you can be flexible with the application of the code to properly bill for what is going on. It helps as a really good descriptor. And so we'll see this consistently. Everything grows like as an increment of 1. And all of these will have multiple types of codes that all do this. And this will be just standard procedure in general. So here, I want to make a quick disclaimer that specifically there are no CPT codes or HCPCS that are specifically set for substance use disorders. Instead, CPT codes and HCPCS are applied to patients who are going through any type of substance abuse disorder. So altogether, there's nothing specific that we can link to that for their own, to have their own 5-digit code or something like that. Instead, we just apply the necessary ICD-10 code, and then whatever type of CPT or HCPC that properly links with that. So going to here, a lot of the times with SUD patients, 99202, 99203 will be very common. Again, these are E&M codes. These are just for simple office or other outpatient visits for evaluation and management. So 99202 is specifically for a new patient. And then it focuses on the physician will then focus on their problem history. They'll do a problem-focused examination and straightforward medical decision making. And this usually takes about 15 to 29 minutes. Now, if we escalate that to 99203, it will be the exact same thing as a 99202, except that the amount of time that the physician spends with the patient has increased to 30 to 44 minutes, and the problems are now considered to be low to moderate severity. So as you increase the number, again, that fifth digit, it also may increase the severity, the amount of time that the physician is meeting with the patient, and also other specifics that add to the workload of the physician and the other attending professionals working alongside the patient. So again, we have 99204, 99205, and I wanted just to make this easier so that I put in red the 99202, because this is kind of what I was saying before. 99204 is the same thing as 99202, but it's in addition, it has a detailed history, a detailed examination, and all of those increases in the type of care, because they're getting more care because there's an increase in time, the severity is increased. Same thing with 99205. Again, this will be a common trend found in all the CPT codes. Similarly, we also have 99211, 212, and 213. Now, these are for established patients. The ones that we were looking for were actually for just new patients. So if you already have an established patient within your record system, again, these are the codes that you would focus on. And then after 211, everything is somewhat similar to 99201, but it just increases more with an increase in the type of a more integrated or focused problem history, problem-focused examination, straightforward medical decision-making, and an increased amount of time that the physician takes care of themselves. So I know it's a lot of repetition, but I like to try and make sure I add different pieces that kind of move it along. But hopefully you get the point, as this is a system that tries to do its best to not take advantage, but to properly understand the amount of time physicians and other professionals work alongside their patients, and to bill correctly for the amount of work and the amount of effort put into that time with the patient. And then, of course, 99214, 99205, these are the most common CPT codes that are billed for, especially in SUD patients. I regularly use this for our own data collection tools and surveys when working with our partners to kind of get a trend of what billing codes we see the most often for. So a lot of the times, the majority of the majority of the meetings between physicians and patients tend to be between 30 minutes to an hour. So, and that is encompassing 99214 and 99215. Additionally, because we are now working, we like to work in a telehealth capacity. A lot of times, specifically with our telehealth sites, a modifier will be included. And so I don't fully go into the full depth here. I have a link inside of this presentation to kind of address that, to kind of give it its own introduction to telehealth, which was generously provided by the UMTRC, which Cameron has been working so hard to kind of just build and steward and grow that area of IRHA. But specifically, say, for example, if you have 99214 and an individual's they're not meeting, with a physician face-to-face, COVID, everything like that. Instead, they might add, okay, we'll put a dash and then put GT at the end, or GQ, which would denote a specific type of telemedicine care, or it just meaning that say if I put 99214-GT, the patient would be meeting for 30 minutes through like a Zoom call or through a specific type of HIPAA protected Zoom call for the sake of just having a regular visit. So we now know that evaluation and management service, we can bill for established patients or new patients just using telemedicine practices, just by adding a modifier that could be -GT or GQ. So that's now a great way just to make sure you're billing for the correct amount, and also to increase access to patients who may have barriers to just even getting into a physician's office. So here's a little E&M code summary. I've been throwing a lot of jargon. I've been throwing a lot of information at you. So I thought this table would be a lot easier. So when we look at 99202, which is for new patients, and 99212, which is for established patients, we can see the medical decision-making is straightforward. And then if I move across to the right, the complexity of the problems addressed is minimal. The amount or complexity of data to be reviewed and analyzed, minimal. Risk of complications and or morbidity or mortality, minimal. And then you can see with 99203, 99213, same thing. It's low, low, limited, low. And then as the number increases, the fifth digit, we have moderate, 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 and then 99205, 99215, high, high, extensive, high. So this is for both new and established patients, just for E&M codes. Again, if you're doing this and you're utilizing telehealth services altogether, you just add a -GT or a -GQ. And there are other more specific type of modifiers that you can add to kind of boost that and to show your use of telehealth within the system. So hopefully this kind of is a roundabout way of kind of showing you like the different types of CPT codes that are most commonly used. And then again, when we go to SUDs, codes for SUDs and abuse, these are office consultations. Again, 99214 to 242, 243, 44, and 45. Here is the national non-facility payment and reimbursement scale that we have going on. I believe this was as of, this might need to be updated a little bit. I would have to go check, but this is the most up-to-date information that I was able to find. So there's the national facility payment starting at $33.56. And then again, as you increase up to 99245, you can see the payment also scales appropriately. So again, you can evaluate the national non-facility payment versus the national facility payment. And so these are some reimbursement rates you can kind of gauge to evaluate for consultation codes. So again, this is just for a professional second opinion when a patient is meeting with another healthcare professional. All right, so now we have HCPCS. These are definitely different. They will begin with a letter through A through V, followed by 4 digits. Level 1, CPT codes used to identify services procedures provided by medical professionals in healthcare facilities. And then the reason why we call it level 2 is because it's an alternate to CPT codes, because instead it covers services, supplies, and equipment that are not covered by the CPT codes. They are in the public domain, they're free to use just in general, but it's important to know that while CPT codes are generally, that's what people tend to use, the HCPCS tend to pick up the slack that CPTs don't necessarily cover when we're especially examining supplies and equipment. And then level 3 HCPCS, those will be local, so they're not nationally accepted. They're more just for what the issues for a specific smaller community that's experiencing. So a certain code may be developed, maybe for an emergency, for example, so that they can bill appropriately. I will say this though, sometimes, even though they're not nationally accepted, they may pique the interest of certain healthcare agencies, and at one point they may be eventually added into the official coding books if issues such as that persist and it becomes somewhat of a primary issue that needs to be addressed. And I will say with HCPCS, as I'm about to show you the as they start from letters A through V, Not all the letters are used in the alphabet. You will notice that some of the letters are skipped. I will be honest, I'm not exactly sure why. They have their own system. So some letters will not be used, but they follow from A through B. So we have A codes that focus on transportation services and other medical and surgical supplies. It will also include administrative, miscellaneous, and investigational. There are the B codes, which are for enteral and parenteral therapy. C codes that are temporary with outpatient prospective payment, so OPPS. E codes, durable for specific durable medical equipment that only apply to durable medical equipment. G, procedure professional services. That one is the most popular for SUD related reimbursement, mainly because these are similar to the E&M codes that CPT codes use. And G codes are also constantly used for telehealth or other types of telemedicine provisions. So we have then H codes. These are the temporary national codes for government entities. J codes for drugs administered, and then K codes, which are assigned to DME MACs. Then there are L codes, orthotic procedures, M codes, medical services, P codes, pathology, Q codes, procedures, services, and supplies that are on a temporary basis. I hate to read through all of these for you, but you kind of get the picture. Again, the point is that there is a code for everything. There's a code for every situation, a code for every type of billing that you can imagine. And if necessary, new temporary codes can be created in order to properly bill and reimburse, whether it's a big hospital, a critical access hospital, rural hospital, it all goes. Again, R codes, STV. Again, notice there's no U. That's done deliberately. I put that note down here. There's nothing for DFINOU. So I'll leave that for you to read and evaluate on your own. And so now I'll focus, because Indiana Rural Health Association is a rural organization. I want to focus on the rural codes a lot that we see, such as G codes, which I already mentioned previously. So we have G2064, minimum of 30 minutes with a primary care medical professional. G2065. And G0511, specifically G0511 is for FQHCs or RHCs. So that really is important and will most likely be seen, again, within a rural capacity. Then, of course, as I mentioned before, we have the telehealth G HCPT codes. So there's G0210 for telehealth visit online only. And then there's emergency telehealth codes. There is G2025 for telehealth audio. Again, as I said before, it continually specifies, and constantly there's something for everything. And then I can draw your attention back at the bottom to G0071, which is submit with FQHC claim for payment. So specifically for those federally qualified health centers, can be done using only G0071 or with an unpayable service. Here, I just threw this in just to kind of evaluate. Here's the HCPCS decision tree. So these are, again, requests to add or revise codes. And this is kind of the step-for-step process of how new codes can be added. And yes, codes are revised to properly keep up with whatever ailments, illnesses, and issues or services and new advancements are made within the medical field. So here you have, starting at tier 1 was the application timely and complete. Again, timeliness of an application to add or revise a code is the number one thing. And then you can evaluate and see just the continuous map and how certain requests can be denied, and all the steps that are walked through to make really important decisions about adding and revising different types of codes. So I'm not going to focus too much on this map, but I just kind of wanted to show you so you have an idea of how these codes run through each other and constantly grow, transform, and to a certain degree kind of mutate to properly adapt. Now this was probably the most helpful also for myself to keep everything straight, HCPCS versus CPT. I like to keep it, basic and understand it myself so I can explain it better. If we're looking from a metric standpoint, if we look, I have value, divisions, creators, and the reason for use to kind of go through this. So again, HCPCs, they're the description of the delivering of the services, and the CPTs are the actual services that the medical workers provide. And then if I flip over to divisions, like HCPCS has level 1, 2, 3, CPTs known as category 1, 2, 3. And then the creators, obviously this is important. HCPCS was created by CMS and CPT was done by the American Medical Association. So that's something that I myself don't always constantly remember, but it kind of helps to know that if you can evaluate, like CMS and AMA work together so that codes can seamlessly work together. And CMS developed HCPCS obviously to help pick up the slack with the CPT codes to properly bill for those additional services as well. That's not always the case, but it's something just important to make note of. And then the reason for use, which is I think one of the most important, HCPCS, they have codes that are to be applied either directly or non-directly to healthcare workers, and the CPT codes are those procedures that the workers actually do to be operated on a patient. And so here's another quick piece, identical procedure. Well, this is when to use. So identical procedure or service descriptors. So I'll give a little bit more backstory on this one. A lot of times CPT codes will also have a matching HCPCS code, and they'll be exactly the same in both the code books. Whenever there is you find an identical code between a HCPCS and a CPT code for the exact same service, you're always going to use the CPT code. However, if the primary insurance provider of the patient is Medicare, then you want to focus on the HCPCS. Then you want to use the HCPCS level code. So if I go over that just one more time, if you have, again, if you're billing for a specific type of service and you have a CPT code and a HCPCS code, use the CPT code. However, if the patient has Medicare, then you're going to use the HCPCS code. And then if you have similar but non-identical procedures, so there could be some wording that's a little different, but to a certain extent, you're billing for something similar, you're going to use the HCPCS code. And then again, I made another table just to kind of really condense this. Here are the different classification systems. Again, ICD10 are diagnoses, CPTs are the services rendered, and then your HCPCS are going to be your tools of the trade. And so again, what the patient has or is experiencing, again, that's ICD10. What the medical professionals will do about the ailment is the CPT, and HCPCS, not all the time, but a lot of the time, the equipment, tools, and support services needed to fulfill the patient's treatment. And so specifically, I did some more research specifically focusing on Medicare reimbursement. Again, there's no category that specifically addresses substance abuse treatment. Instead, again, CMS will just provide services for substance abuse disorders only when reasonable and necessary. So through those E&M codes that we talked about, additionally, that will be done in tandem with the ICD10 codes to address that. And if telehealth is part of that, the CPT code will have a modifier attached to it, set with a -GT or a -GQ on top of that. And I also included this PDF that was provided to me by Cameron Hill, who works with IRHA as leading the Crossroads telehealth program, and alongside, and has really blown up the UMTRC program as well. And so he provided me this PDF that gives a really nice understanding of just telehealth in general, and it includes those modifiers as well. So that's a great resource as well. And then moving forward, inpatient treatment for Medicare reimbursement, professional services reimbursed as inpatient stay for professionals not recognized for separate billing, and then directly to professional if under Part B and recognized as separate from inpatient stay. And then medications are bundled into inpatient payment. And this is just kind of how the reimbursement kind of just works specifically for Medicare. And I know reimbursement is not, the most popular topic always focused on, but I also recognize the need for it because it's not always, again, it's not the most popular topic to present on, but it's necessary. And then when we're looking at reimbursement from an outpatient standpoint for Medicare patients, eligibility for reimbursement is dependent on the provider of services, Coverage and payment is based on service by service basis. And then again, I don't have to consistently read off of everything, but again, substance abuse treatment this is the important part. Substance abuse treatment is not considered to be an independent provider type. So obviously, all of you are familiar with Part A and Part B. I thought this was just important just to add in there when we're talking about reimbursement and Medicare alone. So I'll just jump on to the next spot. Other covered services, psychotherapy. So this could also be linked to behavioral health and other telehealth services, as we discussed before, from a CPT and HCPCS standpoint. Patient education, post-hospitalization follow-up, prescription drugs under Part D of Medicare, and then inpatient prescription drugs, and ESRI, structured assessment and brief intervention. So to go over that super quick, I want to just check my time here to make sure we're doing well. Okay, we're doing all right. ESRI is a really great intervention approach that I myself have been utilizing and working alongside with Dr. Amna Anwar, with IRHA, and with one of our contacts, just to develop, an understanding of, is ESRI being used? Is it popular? How is it being efficient in its intervention approaches? It focuses on screening to assess the state of the patient. You want to engage with the patient and just refer them to treatment, whether therapy or other additional resources that are required. So here, I have additional resources that I added here. I was doing my own personal research just to kind of evaluate, are there other types of programs out there that are being used right now within the the SUD side of patient care. I stumbled upon the Innovation Accelerator program. This was done in Kentucky, Louisiana, Michigan, Pennsylvania, Texas, and Washington State. So its aim is to expand coverage, better identify people with SUDs, provide incentives for favorable outcomes by establishing payment mechanisms and models. And so this has been something that's still, I think, in the trial process. I'm not sure if we'll see the continuation of it yet, so I'll have to continually do more research on that. But that's kind of just another idea of what's going on that we have, moving forward at the moment. So that's everything so far that I have. I tried to move a little bit more quickly than last time that I gave this presentation, because it was just chock full of meat. So I can open it to questions, Cam, if that's what you would like.
Absolutely. Yep. So thank you, Micah, for this presentation. We'll go ahead and open it up to questions. Feel free to put any questions that we have in the chat. I'll go ahead and address one of the questions, which is asking if we can get a copy of the slides. So absolutely. What we'll do is when we post this webinar to our YouTube channel, as well as to our archived webinars on the UMTRC website, that will also include a copy of the slides. So typically it'll take about a week or two just for us to, get the video edited, put it online, but you'll be able to grab the slides from there here shortly. But any other questions that anyone has, feel free to go ahead and put in the chat. And I can kick us off with a question. So Micah, what's kind of your experience, as you've worked with NROC, what are some of the biggest challenges that you feel like rural communities face when it comes to substance use disorders?
I would definitely say there's a lot of barriers to entry. And when you examine, this is not the case, again, for every patient, but you could say, depending on the demographic of the rural community, the associated comorbidities. So if you're examining, if you want to evaluate, diabetes, infant mortality rate, and different pieces of that puzzle, you could say that, there are some mobility issues that can be attributed to that. A lot of times, comorbidities, especially with behavioral health, when we're looking at anxiety, personality disorders, any type of mental health disorders that we're looking at, those will always be a really good indicator of kind of not. I don't want to say 100%, because I don't want to put anybody in like one category in one hole. But a lot of times we can find trends just to evaluate what ICD-10 codes do we find, and does that link over to their need for, to be able to be even mobile to get to a physician's office, to even have an E&M code done for them. Because a lot of them, especially with Crossroads and NROC, which is really interesting just how they overlap, is that they may have mobility issues. They may not have a car or have a ride, and they may be ashamed of the fact that they're dealing with an SUD, because a lot of times in rural communities, again, when you bring drugs into the subject, that's just a street drug. That doesn't apply to me. So taking pills is not as bad as injecting. So there's that erroneous comparison that's made, and in doing so, it kind of it misleads individuals. And so by the time they get wrapped up into that and they do face that type of diagnosis, it can make a very odd mixture for that individual. It can make them very uncomfortable. And so that all of those kind of create this very, very complicated barrier when doing it. So that's why telehealth has been a huge, huge, huge step in the right direction to get these patients just the care and the attention they deserve, and just moving forward in a way that's respectful, that they feel respected, at the same time that the physicians and the people that are tending to their care can be trusted and are in it for their best interests. So again, the key barriers, again, I would say like mobility, access to a vehicle, just straight up distance. The distance alone is crushing for some individuals. And so do you expect them to drive 50 minutes to an appointment when maybe their car is already on its last legs, or they have other family members to take care of, or things like that? It's not really going to happen. So telehealth, telemedicine in general, that's just the number one way to kind of take out those barriers. And again, we could also make the argument like access to fiber optics and an established, internet system and infrastructure. That is another thing that also needs to be addressed, I would say, as well, because then they would have to rely on that distance and driving. So that's a whole nother piece.
Yeah, absolutely. Yeah, and that's a great point, especially when it comes to, being able to address some of those barriers that individuals may have, whether it be, the opinion of other individuals in their community, or just being able to get to an appointment in general. And a kind of with this presentation, I'm with some of the members on our audience, they may be interested to, you go through the process of knowing all the billing so you can get reimbursed for the services. But also you can use the billing information that you're using for your either telebehavioral health program or just your behavioral health program where you're seeing patients in person, to really be able to gather some insights as well from the data that you get from that. So Micah, can you tell us just a little bit about your experience, utilizing billing data to kind of tell a story?
Yeah, so when we evaluate the data that we have, a lot of the times it's just interesting to see if we make either a pie chart or just a table or a cross table. We can really see, just evaluating the ICD-10 codes are huge. Just in general, it may seem super simple and obvious, but when you cross-reference and see the different types of codes that are attributed to a patient, it opens that book up really, really wide. For example, for our collection purposes, we've opened it up to take up to 4 ICD-10 codes to evaluate, the full, just to evaluate the full scope of the individual's ailments. And so sometimes I've seen 5 or 6, but usually, sometimes there's 1 or 2, but usually we can get 4 in there. So sometimes I'll see somebody who will have a very common one, F41.1, which is a low to moderate general anxiety disorder. And that could be linked with F12, which is the cannabis disorder. And then on top of that, it could be linked with, there'll be an F11, which will be, I believe, an opioid disorder of some type. And then when you see those 3, I like to stratify the data and collect that and kind of sum up all the different types of codes that we see. And those are like the top 3 that we consistently see over and over again. And so I'll rate those and I'll top 5 them and then kind of show them to our county partners and evaluate, like, these are the codes that are coming in that are the most common. You're dealing with anxiety, you're dealing with cannabis use to quell that anxiety. And then you're also using, you have individuals who are also touching, say, prescription medications and maybe abusing those. And so in doing so, you tell a story with that data to like a hospital partner, for example, and say, like, hey, so these are the top 1. So anxiety is huge in the area that you're serving, specifically for telebehavioral health. And so by doing that, I can give really very granular data, and that's very specified and tailored to a specific county, just by evaluating and doing frequency reports. If necessary, I'll open up R and run just a trend analysis to get an understanding of and evaluate the correlation of this specific ICD10 code and then what CPT code I'm getting. So a lot of times, like, for example, if I'm getting F41 and that F11 code that I talked about, I'll see a lot of 99214 and 99215, which is, when I combine those together, that is a meeting of like moderate to maybe higher severity of a problem analysis from like 30 minutes to an hour long. So then from there, I can tell the story and say, okay, so your physicians are currently meeting between half an hour to an hour, not 10 minutes to 20 minutes anymore. It's now 30 minutes to an hour. So that's a deeper problem set that you're working with. That means more time and more energy is being, utilized to work with a certain patient or something like that. So now you understand, how much effort are my physicians putting in? How much are my nurse practitioners putting in? How much are my LSWs putting in? You're starting to see like where everybody's workload is at, where the need is at, and the severity of the different types of, whether it's addictions or just inherent, ailments or mental health disorders. So you can tell those stories, and just by putting things together, running frequency counts or putting it in R and running a logistics report, I can tell that to my, to the hospital partners and give them a story that allows them to further serve their county.
Yeah, absolutely. And, that really helps, a behavioral health program to really be agile with whatever the needs are coming up with the population. And, some of the big ones that you'll always see when it comes to, substance abuse as well as behavioral health as well is, anxiety and depression are usually always going to dominate as far as, some of the leading factors why people are seeking out care. But, even being able to see like the small nuance changes, if you start to see, individuals that are coming in with a certain type of substance use disorder more consistently than you have in the past, being able to kind of see those trends before they become a huge problem can really help, your program be a lot more agile, regardless if you're coming from what perspective you're coming from, whether you are a provider yourself, if you're an administrator, or working as like a consultant within those cases too. It can help make those programs more effective long-term and hopefully catch some of those things early on when it comes to different changes in your patient population.